All right, thank you all so much for joining us for today's CTeL webinar on RPM Oversight and Enforcement, What to Know for 2026. We are grateful to be joined by Natalie Lorenz, who is a Senior Associate in the Powers, Piles, Sutter, and Verville Healthcare Practice Group, specializing in healthcare regulatory and compliance matters, including Stark and anti-kickback laws, Medicare and Medicaid billing and reimbursement, and telemedicine regulation. Thank you so much for joining. I'll turn it over to you.
Thanks, Lydia. Hi, everyone. My name is Natalie Dobek-Lorenz. As Lydia says, I'm a senior associate at Powers. This is going to be a presentation on remote patient monitoring, oversight, and enforcement. And I was inspired to do this presentation because I attended a conference that the American Health Lawyers Association put on. And in that conference, we had individuals from the Office of the Inspector General there, and they spoke directly to RPM being a area of concern in fraud and abuse, and particularly an area that they would be looking to ramp up enforcement in 2026. And so, while I think there's existing things out there from the OIG, which I'll get to, that point to that increase in enforcement, I wanted to make sure that stakeholders were aware that this really is an action item for HHS and OIG looking into 2026. So while remote patient monitoring includes both remote physiologic monitoring and remote therapeutic monitoring, I'm going to focus on remote physiologic monitoring, which I'll refer to as RPM throughout the presentation, because that is what the Office of the Inspector General and CMS are currently focusing on. Medicare covers both services differently, as I'm sure you know, and I'm happy to get into those requirements. You can reach out to me and I'm happy to do a presentation that kind of contracts both of those. But I'm focused on remote physiologic monitoring from the fraud and abuse angle. So, as I said, I attended this conference where the OIG identified RPM as an area for fraud and abuse. And we also saw this in the fall 2025 semi-annual report to Congress that the HHS OIG put out. And in that report, there's a specific section in which they identify the rapid rise in the use of RPM as an area for enhanced oversight for fraud and abuse. And we see that played out in the data and reports that OIG has issued since, that the use of RPM in 2025 and 2024 exceeds $500 million per year in Medicare payments. And nearly 100 million Medicare enrollees receive some type of remote patient monitoring during that time. And about 4,600 medical practices routinely billed for some type of remote patient monitoring. In that report to Congress, CMS OIG recommended that CMS consider several measures to both um, detect and prevent fraudulent claims, which I'll address later in the presentation. First, I want to talk about, as I mentioned, this presentation focuses on fraud and abuse within remote physiologic monitoring and what to look out for. So I want to talk about what fraud and abuse laws are we talking about? And specifically, we're focused on the Claims Act. So under the civil FCA, it's illegal to submit claims for payment to government programs, which I think most relevantly includes Medicare and Medicaid, that you know or should know are false or fraudulent. Under the civil FCA, a provider can be liable even if there's no specific intent to submit a false claim. And I can tell you, I work on fraud and abuse. That's my main area of focus. Rarely is someone intending to submit a false claim or defraud the government. These are inadvertent errors. However, though, the government doesn't care that there's no intent. And if the person acted in the legal standard is called deliberate ignorance or reckless disregard of the truth or falsity, then they can be found liable. And so that means that providers need to be aware of what would constitute a false or fraudulent claim, meaning that the requirements in this case for billing RPM need to be met. And there's civil monetary penalties that attach to violations of the False Claims Act, and there's also a criminal component. And the fines include the penalties there include imprisonment and criminal fines. I want to get into what we've seen from the OIG on enforcement and also reports. And I'll go chronologically in recent years. So first we have a 2024 report. And in that report, the OIG looked at RPM utilization specific to Medicare from 2019 to 2022. And they found a tenfold increase in RPM utilization. And again, this is focused on remote physiologic monitoring, which they denote in the report. And during that time, Medicare payments increased from 15 million 2019 to more than $300 million in 2022. And when OIG looked at the specific claims that they were auditing, they found that 43% of enrollees didn't receive all three components of the monitoring. So that includes first, the patient education and setup, second, the device supply, and third, the monthly treatment management. And in this report, the OIG made preliminary recommendations to CMS to strengthen the oversight of remote patient monitoring. So, number one, they wanted CMS to implement additional safeguards for when remote patient monitoring is to be used in builds. So, essentially, more requirements. Number two, they wanted to require that information about the ordering provider be included on claims and that encounter data was collected for remote patient monitoring. Number three, they wanted to develop methods to identify what health data is monitored, specific for each claim. And number four, they wanted to conduct provider education for billing of remote patient monitoring. And they also wanted to identify and monitor vendors that billed for remote patient monitoring. In that same vein, the OIG announced in 2024, following this report, that it would be conducting an audit of Medicare Part B RPM services. And this audit is, as you may be aware, is ongoing. Providers and vendors are being contacted, and it has an expected issue date of this year, and we're hearing that that's accurate. And OIG noted broadly that they're determining whether providers have furnished or billed for RPM services in accordance with Medicare requirements. And so that was the focus of the audit. But again, we're hearing that vendors are also being contacted. That was 2024. Not long thereafter, about less than a year, in August of 2025, the OIG released a data report on the use of RPM. And in that report, the OIG analyzed about 4,600 medical practices that, quote, routinely billed for RPM services. And again, this review covered physiologic data. It didn't cover non-physiologic data, which would be remote therapeutic monitoring. And the typical use that OIG found was that medical practices billed for remote patient monitoring for about 70 enrollees during the year and added about 5 new enrollees per month. And that frequency is to be noted because when the OIG looked at those 4,600 medical practices and associated claims for RPM, they found 5 areas of problematic billing patterns. And these are 5 areas that I I am recommending that practices focus on. And when we'll get into recommendations later, but the recommendations build upon these problematic billing patterns. And so, number one, the OIG identified spikes in new provider enrollment or new patient enrollment, excuse me. And when they looked across the practices, they saw that 32 practices showed sudden growth and that one billed for over 3,000 patients in a single month. So when we're seeing about an average of 70 enrollees during a year for each practice, 3,000 a month is going to be a large concern. And that is going to have the OIG take a second look. And so when providers are looking at enrolling patients in RPM, I recommend that you be aware of where there is sudden growth, if there is anything, and how that can be explained using medical necessity. And so we needed to provide RPM because we developed this relationship with a provider who identified this product, and this is a way to serve our patients. And it meets all of the requirements of RPM. And so, again, we want to be able to explain that these patients who are receiving RPM meet the medical necessity guidelines from CMS. The second area of concern is billing without a prior patient relationship. And CMS requires that medical practices have a prior relationship with a Medicare enrollee to bill for remote patient monitoring. So that prior relationship needs to be either an in-person visit or a telehealth visit. When OIG looked across the medical practices, they found that 45 practices lacked that prior relationship for over 80% of patients. And so, again, that is a clear area in which practices are not meeting the RPM requirements. Number three, the OIG found that 52 practices billed for device codes without corresponding treatment management in 75% of patients. Treatment management is not necessarily required. However, or there may be instances in which treatment management is not required every month. But when we're seeing that 75% of patients of your patients are not receiving treatment management, that's going to indicate that potentially this is not being provided in accordance with CMS requirements. And I would have some concern about medical necessity or false claims. Number four, the OIG looked and saw that multiple providers were billing for the same patient, which cannot happen. It can only be billed once per month. And so they saw that there were 34 practices that continuously shared patients back and forth. And this raised a concern about which claims were valid and which claims were false. When the OIG also looked at these claims, they found that some practices were billing for 2 or more devices for the same patient every month. Generally, you can only bill for one remote patient monitoring device per month per enrollee. There are exceptions. But again, when that's being done continuously, it's going to raise a concern for the OIG. And so this report was from August 2025. Enforcement has already started for RPM, and I'm going to get into that in my next slide. So we have the health wealth settlement. In this settlement, the investigation started because former employees of Health Wealth filed a whistleblower claim under the False Claims Act, which is called a qui suit. And the United States alleged, and the whistleblower alleged as well, that the director and owner of Health Wealth caused claims to be presented to Medicare for services that were not reimbursable. So, specifically for these services to be covered by Medicare, the device itself has to automatically report readings back to the monitoring company without further human intervention. That mechanism needs to be automatic. And in this case, Health Wealth was knowingly billing for RPM services, even though it failed to provide patients with devices that met those requirements. And it did so for 3 years. And so when we look at this settlement and we look at the $1.29 million that was paid to settle, this demonstrates that the OIG and DOJ is increasing enforcement around RPM billing, and it does see RPM billing as a False Claims Act risk. And I think that that view is only going to increase again because we've seen them identify RPM as an area of fraud and abuse enforcement, and we've seen the audit that is ongoing and will be released this year. So I am concerned with the release of that data in 2026 and with the release of those results that that will spur even further enforcement. But there are things that we can do to prevent issues moving forward. So RPM codes must, or the specific diagnosis codes need to clearly reflect the condition being monitored. And so that claim should include the diagnosis code. We also want to make sure that there's clear record of the prior patient relationship, the medical necessity, the fact that the device was provided, and treatment management. I also want to make sure, as far as internal policy goes, that there's policies on the use and regular review of RPM billing data for those OIG areas of concern. So those 5 areas that the OIG identified in the 25 report. I would also recommend that, and this was one of the OIG's recommendations in the 2024 report to CMS, that providers be required to have training on the RPM coverage and billing requirements. For vendors, I want to make sure that the contracts address device and transmission standards. Again, that was in the Health Wealth settlement, the fact that the data wasn't being automatically sent back to the company. I would also recommend that marketing practices be addressed in the contract. Marketing in healthcare relationships is a high area of risk. It can be done correctly, but it is a high area of risk identified by the OIG, specifically in violation of the anti-kickback statute, which at a high level prohibits remuneration, anything of value paid for referrals. And so marketing can be implicated there. The device itself should meet basic coverage requirements like being able to collect and transmit data automatically. Related to the anti-kickback statute, the compensation paid for any services should be fair market value. And as far as the governance goes for the vendor, I would want to be prepared to respond to OIG or CMS inquiries. All right, now I'm going to get to questions that you all may have. And I also just want to make a note that this presentation is not legal advice, shouldn't be acted upon as such, and is subject to change without notice. There's a lot changing in this industry and area, but I am happy to help either now or offline. I've provided my email there. Do we have any questions? And also feel free to drop questions in the chat. Okay, we have one question from Rachel Carey. Do you have any specific concerns that you've seen with RTM and facility billing? Rachel, I can get back to you. That was not the focus of this presentation. I'm happy to get back to you with RTM thoughts. Um, but I think that's a great question. Would you mind, Rachel, dropping your email or sending me an email? Thanks. How about you, Lydia? I know that you have done some work in this space.
Yeah, looks like we have just want to make sure we get to the question in the chat. Have you had any concerns around new devices being used in RPM in the rebate in the eye care space?
Yes, I do have concerns. I think there's been a rapid expansion on use of these devices. And again, what you're going to see there is that the increase in the number of patients who are using RPM in that practice, it's going to look like you have this massive expansion. And that's something that the OIG is, when it's auditing these claims, it's going to stand out. And so I think that's where I was trying to touch in the presentation, that we need to shore up the medical necessity and the reason behind these new devices and what they are meant to treat. And so I would say if you're a provider, that really press on the literature and get information on the use of this device, what it's treating, what information the vendor has about its success, and also look at that data transmission as well back to the vendor.
I wanted to ask if you've seen any effects on the new access model. That's something that CTeL's been tracking closely. And if you think that either participants in the access model or the growth of this model might have an effect on how OIG uh, views its RPM compliance strategy.
Yeah, I think usually when participants are participating in that type of model, that would not be an area of concern for the OIG. And I can't promise anything, but I'm not concerned so much as participants in that model. Does that make sense, Lydia?
Yeah.
All right. Well, if we don't have any more questions, I think we'll give you some of your time back. But again, my email is my last name and my first name dot last name at powerslaw.com. Happy to answer any questions offline. And thank you everyone for your time.
Great. Thank you so much. We really appreciate
Thanks.
it.
Bye.